All right, so we're in chapter 6, which is the integumentary system. These are the different conditions that we're going to learn today, and this is only like the tip of the iceberg when it comes to dermatology, right? There's just so much, but I try to pick out like the most common and the most, like, the ones you'll see most likely with skin conditions. So as you're reading through the chapters and you see something that isn't on this list, again, just skip it, okay? So only focus on reading from the textbook the conditions that are on this PowerPoint, okay? All right, so just a quick kind of bird's eye view when it comes to skin. There are generally, most of the skin issues fall into one of these categories, okay? So there's either going to be a skin issue related to an allergy, right? Someone has an allergy, they break out in hives or something, right? So that's an allergy causing a skin issue. Another broad category is like a fungal or yeast infection. You never had anybody ever had like athlete's foot or like ringworm or something like that? But ever heard of those? Yeah. It's like just a fungal or yeast infection. Another broad category is viral. So there are some viruses that can cause kind of skin breakouts. Bacterial is another main cause. So some kind of bacteria is causing some kind of infection. Another is autoimmune. We talked about that last week, the autoimmune infections. There are a lot of people who have autoimmune conditions. A lot of the manifestations appear on the skin. So that's another category. And then lastly, we have just kind of like growths in general, whether it be anything from like a wart or like a tumor, right? So those are kind of growths. And those fall into two categories, whether it's malignant or benign. Who remembers what malignant and benign mean?
Malignant is
cancerous, and benign is just, it's a growth, but it's not cancerous. And you can't always tell by looking, right? So that's why they often do biopsies. You guys know what a biopsy is? They like stick a little needle in there and kind of draw some cells out, and then they look at those cells under the microscope to tell whether or not it's cancerous or not. All right, and then broadly speaking, these are usually like the kind of treatments that go along with those causes. So if it's an allergy, typically you're going to give someone an antihistamine. That's just going to calm down the allergic response. I mean, there's other things as well, but this is kind of broad categories here. If you have a fungal infection, they're going to give you antifungals. That's pretty easy to remember. Viral is going to be antivirals. Bacterial is going to be antibiotics. For autoimmune, this ties into what we talked about last week. Steroids. Who remembers how steroids work? This is going to be important. Huh? Right, so it suppresses your immune system, right? Because with autoimmune, remember, your immune system is attacking yourself, and that's bad, right? We like our immune system to attack bad things like viruses and bacteria, but it's a problem when our immune system is attacking us, because we need us, right? So that's what steroids do, is they suppress your immune system. And then biologics and DMARDs, these were just two broad drug classes that are specifically used in a lot of autoimmune conditions. And then for growths, typically it's not going to be mostly like a medication, it's going to be mostly like a surgery. So cryosurgery, anybody know what that is?
Yeah,
freeze it off, right? So you freeze it off. They do that a lot for like if you have skin tags or warts. A lot of the time they'll do that. Yeah, if you have something on like some kind of growth on the cervix too, they can do those. Then electrodesiccation. Anybody want to shout out what that is?
Something with electric.
Well, kind of, yeah. This is where they actually have. They'll ever heard of soldering? It's kind of like they have a plug-in like little laser, and it kind of like burns off the skin. So it's kind of
like cauterization.
Yeah, exactly. It stinks, let me tell you. It smells real bad because you just smell that burning flesh, and it just, ooh. But yeah, so these basically do the same thing, but just one is freezing, one's burning. So, and then lastly is a Mohs surgery. This is a specific procedure they do specifically with like skin cancers, where they cut out the skin cancer, right? But then they have to keep taking more and more skin until all the skin they remove is not cancerous. So they'll have to keep taking more and more until it gets into the healthy tissue. So it's a specific procedure they do specifically to make sure that they get all of it out, right? Because you can't always tell by looking. You just have to keep cutting and have looking under the microscope and be like, okay, we've got clear margins now, which means it's all healthy tissue. That means you've got it all, okay? So Mohs surgery specifically for cancers. All right, so our first condition is seborrheic dermatitis. And what does the suffix itis mean? Inflammation, swelling of the skin, right? So it's a skin inflammation issue, okay? You might have heard it as cradle cap. If anybody has kids, anybody ever heard of cradle cap before? It's where you get that like greasy.
Oh, yeah, cradle cap.
Yeah, you get that greasy kind of stuff on their head there. So etiology, remember that means the cause. So the cause of this condition is that the oil glands on the scalp are becoming inflamed. Okay, so they're just overproducing this oil. Symptoms of this is going to be mostly the scalp, but also you can do some areas of the face too, like the eyebrows, the nose, behind the ears, kind of because there's a lot of oil glands on your face and hair, right? And this is a picture, just so you can see. This is like a severe case, obviously, but this is like what it looks like, that overproduction of that oil. Okay, so it's very common in babies. Anyways, so it can be itchy. Diagnosis is easy. You just look at it and know that's what it is, right? There's not like a special test or anything. You can just tell by the signs and symptoms. And then for the treatment, you're actually going to use cortisone and hydrocortisone cream. What drug class are those? Steroids, right? We know that because they end in
Zone.
right. So that's one thing you'll want to remember. Okay, so you kind of rub that on there, and it just calms down that inflammation of those oil glands overproducing that oil. Okay, prognosis. Again, what's prognosis mean? Right, like what's the outlook for this disease? Like what's the natural progression? Like is this a chronic condition? Is this, what's the course of this disease process look like? So this is an acute condition. That means it comes on fast and then it usually resolves. It's benign, so nothing really to worry about. It's just more of a cosmetic issue, so nothing dangerous. Any questions on that one? All right, now we got contact dermatitis. So this is another type of dermatitis. Now this one is actually an allergy, right? So your body is responding to a substance that is actually harmless, but your body's treating it as though it were harmful. So poison ivy is an example of this. Some people are allergic to poison ivy, some people aren't, right? Some people are allergic to certain types of soaps or lotions or detergents, and other people aren't, right? So your body, your immune system is like, alert, this is a dangerous thing, and it breaks out, right? So everybody had a poison ivy rash before? Mm-hmm. It's awful, isn't it? It's
Very
like
itchy.
Yes, it's extremely itchy. So what we call those little lumps are called vesicles. They're like kind of blister-like, but they're filled with fluid. Okay, so knowing the terms, what things are called, is going to be very helpful, important. Knowing like which conditions have vesicles and which don't, because when you're reading through doctors' charts and things, that's going to be important to know what those are. They're very oozy because all that fluid inside those blisters is like oozing out, crusting over. They itch, they burn, they sting. They're very annoying. What is erythema? Redness, right? So yeah, again, it's just a hypersensitivity, like allergy response. How we diagnose it is we just kind of ask them like, hey, did you come into contact with any of these like common triggers? You look at them. It's kind of easy to figure out with asking some good questions. Treatment again is going to be a lot of steroids, right? Calming down your immune system so it can stop overreacting to this harmless substance. So like hydrocortisone cream, you can rub it on like with mosquito bites or bee stings or poison ivy. That helps relieve that itching, right? And again, this is very acute. It comes on, it resolves, and here's a picture of like what a contact dermatitis might look like. I've had this before with poison ivy real bad. It's like the worst feeling ever. All right, let's see. All right, and then we have our last type of dermatitis, which is called atopic dermatitis, better known as eczema, right? That's like the more common name. Very common. Here, this is also an inflammation of the skin, but rather than being acute, like poison ivy, it is chronic, right? This is just something that people have all the time, and it comes and goes, has different triggers and different things like that. So, anybody here have eczema?
My daughter has it really bad.
Yeah. So it's kind of just something you constantly deal with, right? It sometimes gets better, sometimes gets worse. Anybody want to share like particular triggers that increase the flare-ups?
Seasons.
The sun. What else?
The dryness.
Yeah, so like the wintertime is probably is worse because the air is very dry.
Mine's mostly when it's a different like body wash or something like that.
Okay, so chemicals.
Yes.
Yeah.
My mom, she had really bad eczema on her feet.
On her feet.
Yeah, and it flare up for no reason.
Yeah. So it's kind of just, it's a chronic condition, right? It's just chronic inflammation that you just try to manage, okay? So people have different flare-ups, depends on different triggers. So stress can be one, climate, clothing. Some people have, some babies have milk sensitivity and they get eczema, so they take them off, they put them on different formulas or different things to try and figure out what it is. In children, I mean, this isn't all the time, but children tend to have more vesiculars, like those vesicles, like we saw here. And adults tend to have more dry, leathery patches, so they look kind of like this. Okay. What else? Anybody know what exudative means? That's the fancy word for ooze. So vesicles that ooze, you might just say vesicular exudate. That's the fancy way they say that. Yeah, it's like it's leaking, you know, it's oozing liquid. Typically, common locations are face, neck, elbows, knees, kind of places that are like they often experience friction, right? You get a lot of friction on your knees and elbows, so like that rubbing can contribute to that inflammation there. Diagnosis, again, there's not like a special test or anything. It's just kind of looking at it and kind of getting a history. It's like, oh yeah, I've had this forever. It gets worse when this happens. Just kind of like, oh yeah, well that's eczema. Treatment goal for this is just to reduce the flare-ups and just manage the itching. So there's special moisturizers people can use, like they're like deeply hydrating to help keep it at bay. Cortisone cream, again, because the issue is inflammation, right? And steroids help decrease that inflammation. Antibiotics might be useful if there's a secondary infection. So sometimes people scratch and scratch and scratch, they like cut into the skin, and then those cuts can get infected. Right? So don't get confused thinking that antibiotics treats eczema, because it doesn't. It just treats if there's a secondary infection on top of the eczema from like scratching and getting an infection in there. Does that make sense? And again, prognosis, this is a chronic condition. It's not curable. It's just something you kind of manage and deal with. Okay? Any questions on that? All right, now we're at urticaria. This is the fancy medical term for hives. Okay, so this one is also an allergic reaction, similar to contact dermatitis, which was like from poison ivy or things like that. So this is a severe hypersensitivity reaction where you break out in hives, whether it's, you know, from eating peanuts or who knows what, right? There's common triggers like bees, some medications. People are really allergic to penicillin, they break out in hives. So anybody can have an allergic reaction to something, you just don't know what it is until you come in contact with it, right? They're usually very itchy. They're like these red rash, and they're not called vesicles, they're called wheals. Not like wheels on a car, that has two E's. This is wheals with an A, and they look like this. So you can tell that they're different from blisters because they're not like blisters that you could like pop and have it ooze out, right? This is more just like kind of diffuse swelling under the skin, right? Can you see how they look different from this? So that one you could like pop and squeeze, right? So those are called wheals. And again, diagnosis is just, a lot of it is just inspection, right? For a lot of the skin stuff, there are a few like specific tests that you can do, but most of the diagnosis is just description of the signs and symptoms. So if you ever coded for like dermatology stuff, getting really familiar with terms like vesicles, exudate, things like that will help you to clue in like which it is. Did you have a question?
Yeah. Can you get hacks from like anxiety and things like that too? Like,
I've never known anyone to have hives from anxiety.
I feel like when people get stressed out, they can also like break out in hives. Never heard that before.
And they could be breaking out in something else. I don't know if it would be hive, because hives is specifically like an allergic reaction. It could be something else that's being flared up. Kind of like with eczema, people have stress, can have a flare up. So it could be some kind of rash. Not all rashes are hives, right? So they can look similar, but there's just a lot of like skin stuff. So it's probably just a different kind of rash. It's probably not specifically urticaria though, unless someone's actually having an allergy to stress. I'm allergic to stress. Have like a note excusing them from school. Okay, so treatment for this, obviously is just try not to come in contact with whatever that thing is. So if you're allergic to peanuts, don't eat peanuts, so avoid the triggers. But if you are currently having an allergic reaction, antihistamines are going to be real helpful. You've probably heard of Benadryl. Benadryl is like probably the most common antihistamine that comes to mind. People that have severe allergic responses, they use those EpiPens. You've heard of those before? So those are people that have like very severe allergies. And typically allergies tend to get worse over time. So like if you have hives to penicillin, typically allergies tend to get worse each time you're exposed. So they can eventually lead up to, we talked about last week, anaphylaxis and angioedema. Do you guys remember that? So this is what the urticaria looks like, but this is angioedema, where you just get massive swelling of the lips, tongue, sometimes the eyes, which makes it like very difficult to breathe, which obviously can be life-threatening, right? So this EpiPens can be life-saving to prevent things like this from happening. Oh, was there a question?
No, I was just gonna. Never mind, go ahead.
Okay. And prognosis for this, what kind of depends if you get treatment for it or not. So like it's generally acute, once you take your medicine and it calms down the immune system. But if there's no treatment, like someone could have anaphylaxis and die, right? So it can be everywhere from completely resolves to death. So it kind of just depends on whether or not people get emergency treatment for it.
My dog's severely allergic to bananas.
Bananas, that's a new one. Yeah, it's interesting because there's like common things people are allergic to, and then there's like people like randomly like I'm allergic to cotton. I don't know, so it's just interesting.
My stepmom found out she was allergic to bananas because I threw one up and she had to clean it up. And
Yeah.
they ended up having to take her to the hospital while we were asleep because of me.
Interesting. Yeah. Okay. Well, bananas. That's new.
Crazy.
All right. Now we're at psoriasis. Psoriasis is another pretty common skin condition. Kind of people tend to get it confused with eczema because it can be very similar. Whereas eczema, remember, was an inflammation issue. Psoriasis is actually an autoimmune disorder. Okay. So the difference here is that this one your body's attacking itself, and that's why you're having these breakouts versus just inflammation and stress and triggers. There are triggers that can exacerbate it because when you're stressed out, your immune system is not at its peak, right? So a lot of times people get really bad psoriasis, like if they're pregnant, because their body's already like maxed out with what it can handle. Again, stress, climate, things like that. Symptoms for this one is they're going to be like silvery scales. They call them plaques. They usually don't hurt though, or have any kind of discomfort. So it's not going to be just like eczema where it's a little bit more itchy. The other thing about psoriasis is that these tend to develop in areas of like physical trauma. So like if you've had a skinned knee, like you fell down and skinned your knee, you're more likely to get areas of psoriasis on that spot of the body. Because whenever you get, a cut or scrape, your immune system has to go there and try and fight and heal it, right? So there's just a lot of immune activity happening there, and since it's autoimmune, it tends to be an area that develops these plaques. This is what it looks like. This person has psoriasis on the scalp, but you can have it anywhere. So you can see how like Bill might think it's similar to eczema because it kind of looks similar. And that's why dermatology can be very difficult, because a lot of times you just diagnose things off of inspection, and a lot of times things can look very similar. So for treatment, again, the goal is just to keep that inflammation down with medications. So it's like steroid creams, various things like that. And then this is also going to be chronic. This is just whenever anyone has an autoimmune disorder, it's always going to be chronic, right? It's not something you can just get over like a cold, right? So like colds, flus, those are acute, right? You have it and then you get better. Whereas any autoimmune disorder, they're going to be chronic things you deal with just forever. Okay, so here's a picture just kind of comparing eczema and psoriasis. So they tend to look a little similar, but you can see how the psoriasis is more silvery, right? And the eczema is more red and kind of irritated looking. Eczema tends to be more itchy. That's why they tend to scratch more. Here's just another picture comparing the two. All right. Rosacea. Anybody heard of rosacea before? Yeah, it's another pretty common one. Yeah, a lot of it is usually in the face. So cause of this one's also a chronic inflammation disorder. Symptoms of this, people can often mistake it for either sunburn or acne, just because a lot of the times that's what people like have redness is from either one of those things on your face. It tends to just slowly progress. Another kind of subset of rosacea is that people can get what's called ocular rosacea. What is ocular? Your eyes. So they can get really like bloodshot eyes. I don't know if I have a picture of that one, but here's kind of what rosacea looks like. You can see why people might think that's acne. Kind of looks like that, that like cystic acne that sometimes people get. It also could look like maybe a sunburn. But what's something that we talked about last week that people might mistake it for? Yeah, remember the butterfly rash with lupus? It also can look like that too. So just keeping that in mind. Yeah, it's not the greatest thing ever to have. Yeah. So treatment, there is no cure for a lot of these things. A lot of these chronic disorders, they're chronic because there is no cure, right? If it did have a cure, then it wouldn't be chronic. So I think that makes sense, right? Really, again, this would just be about avoiding situations that cause your face to flush. So like people get embarrassed or they're like working out heavily. People like run and their face gets red. So typically with that, like people who have rosacea, anytime like they flush or like get red in the face, it tends to like make it progressively get worse. So they try to tell you like, hey, try to avoid, maybe spicy foods that might make your face get hot, or like running or whatever it is that might cause that. So here's some things: sunlight, exercise, extreme temperatures, spicy foods, hot drinks, even some alcohol can make people's face flush. You ever seen like, those big guys that are like at the, watching football and they're just drinking beers and their faces get real red, what I'm talking about? So, yep, that's rosacea. This is actually one of those that tend to be worse in men. Most of the things tend to be worse in women, so this is one of those that tend to be worse in men. So you can see how his looks a little bit worse than hers does. Hers looks more like sunburn, and his kind of looks more like this areas of like, that does look like acne. Speaking of acne vulgaris, this is probably the most commonly known skin condition known to man. Popping pimples since we were like, 13 years old. What causes acne is there's a lot of different things that can cause acne, whether it's like hormones, people going through puberty, sometimes certain foods cause acne. But basically what's happening is that regardless of what's causing it, whether it be hormones, food, or hygiene or whatever, is that the sebaceous glands are like in the skin that produce like the oil. They just get inflamed. Okay, so here is what like their skin looks like. This is your skin layer. This is like a little hair follicle. You can see how it starts getting inflamed and the pus is accumulating, right? So regardless of what's causing the inflammation, that's what it is. We've seen different types of acne. Pustules are ones that contain pus, those whiteheads, people call them. So they're kind of similar. Cysts, these are the ones that kind of look like the rosacea, right? There's not like a clear defined head, whereas you can see with these look like if you poked it, like it would pop, whereas these just look like they would just get annoyed and red. You've got the closed, comedones is just a pore, so pores that are closed rather than like a blackhead where it's like the pores open. So these are just different types of acne. Let's see. So here we go. These are the different types: papules, pustules, comedones, kind of the picture I just showed you. Diagnosis is just, again, going to be inspection. We treat these with antibiotics if the cause is there's bacteria, in the pores. People have gone on antibiotics to help with their acne. There's also something called retinoids, vitamin A. This helps just to dry the skin. So people that have lots of oily skin, like really bad oil, retinoids might help with that, helping to just dry the skin out, reducing the skin oils. And then this one, I've probably heard of. Anybody heard of Accutane?
Yes.
It's a pretty commonly known drug. It's also pretty dangerous. So like people are pretty strict about who gets to go on Accutane, just because there's a lot of like weird side effects that can happen, like suicidal ideation, things like that, and they don't really.
Can't take it while pregnant.
Yeah, it's a pretty like heavy duty drug, right? It's not just like, oh, here's an ibuprofen. Like they're pretty strict with it just because of the side effects, but it does work really well. So those are the main things: antibiotics, retinoids, and Accutane for acne.
So why would they give you that for acne?
Sometimes people have really bad acne, nothing else is working, and if they don't have bad side effects, then it's fine.
Oh.
But they just keep an eye on you. They'll maybe do like
Oh,
a
okay.
trial, be like, oh, not everybody always has bad side effects, right? Side effects are just like, hey, this drug has the potential to cause side effects,
Yeah.
but sometimes people don't have them. You know, like there's we talked about metformin a little bit last week. It's a diabetic drug. Some
Yeah.
people get horrible diarrhea,
Okay.
and some people don't. So it's like side effects aren't always a given. They're just a potential. Let's see. I showed that already.
That's true. It just goes back to like birth control too. Yeah, some people have.
Yeah, some people gain weight horrible
Yeah,
or get
and
mood
another
swings,
person.
or you know, some people are fine.
Yeah.
So
Oh, that's what it is.
what?
Shingles. I didn't know that.
So herpes zoster, people free like, oh, that's herpes. I'm like, well, when people think of herpes, they think of like the STD herpes. It is the herpes virus causes multiple different things. Okay, so herpes zoster is a cousin of like the genital herpes, right? But it's the same virus family. Herpes zoster is actually the same virus that causes chicken pox. Okay, so I don't know if any of y'all had chicken pox. You might be too young. I had chicken pox. So once a virus goes into your body, you have that virus in you forever. Okay, you might not be actively sick, but it's laying dormant inside your body, right? So if you've ever had the disease chickenpox, you have the herpes zoster virus living inside you right now, right? It might not be causing any problems, but it's just laying dormant, right? But when you get triggered later on in life, maybe you get really sick or like really stressed, have an emotional breakdown, I don't know, like have a massive car accident and all your bones are broken, like something that's gonna like stress your body, the herpes zoster can take that opportunity to flare up while you're at your weakest. Okay, so then people can they have the outbreak of shingles. Okay, so it's the same virus, herpes zoster, but it's just a different name depending on kind of when you get it. So when kids get it, it's chickenpox. When adults get it, it's shingles, right? Which is kind of a misnomer because someone could have not been exposed to chickenpox and then get chickenpox as an adult. So it's kind of like the first exposure and second exposure. So the first time you get exposed with herpes zoster, you get chickenpox. The second time that it comes around, it's shingles. I don't know why, it just is. All right, I think in the homework we had look up dermatome. Was that right in there? I can't remember if that was in your homework. Who wants to try and explain what a dermatome is? Missy?
It's an area of skin that it's feeling from one specific spinal nerve.
Yeah, so let me show you a picture here. You know how we have our spine, right, and the nerves come off the spine, right? So, like if this is your spinal cord here, all these different colors kind of just like show you where the nerves go. So like if you have your spinal column going here and you have nerves that come off of the spine going to different parts of the body, those spots are called dermatomes, right? So this is a dermatome, that's a dermatome, this is a dermatome. Does that make sense? It's just showing like on the skin where the nerves are underneath, if that makes sense. Because you can't see the nerves because they're underneath your skin, but like this kind of shows you where the nerves are underneath. So with herpes zoster, I said they lay dormant in your body. They're laying inside those nerves, right? So they live in your nerves, and then when you have the rash later on in life, it will show up on the skin right above that nerve, right? So that's why it says it forms along a dermatome. So like you'll see on this picture, here's the nerve coming off the spine, right? And it's following the path of that nerve. Does that make sense? So you can see like that dermatome would be like here. Does that make sense?
Yeah.
Because like it's infecting the nerve and it manifests on the skin above that nerve.
That's so strange.
It's weird, yeah. So that's just what a dermatome is anytime you hear the word dermatome, it's going to be shingles. That just goes hand in hand. And something important as part of the symptoms here is that it's going to be unilateral, which means one side. If you hear bilateral, that means both sides, right? Because uni means one, like unicycle, and bi means two. Bicycle, right? So you'll see that on this guy here, you can't see his whole body, but it's only showing up on this one side. It's not also showing up on the other side. So that's one thing that shingles does that's very unique, that makes it easy to diagnose. is that it will show up along a dermatome, it will be unilateral, and it will never cross the midline. So you'll see here again that again, you can't really see his back, but they're showing you here, it doesn't cross the midline. The midline is the spine, so it won't ever go onto the other side because the nerve doesn't go over there. Like this nerve is just right here. Like this nerve over here is a different nerve. Does that make sense? Because the virus is laying in one nerve. And you don't know what nerve it's going to be. It could be a nerve of your face, it could be a nerve on your arm, it could be a nerve on your leg. So it can be more dangerous, obviously, if it's laying in a nerve on your face, because it could be right next to your eye, and like people can get really bad complications, maybe blindness, if it like infects the nerves of the eye. But a lot of them are very common to be on the trunk, like on the abdomen or the back. Do you have a question?
about to say that.
What were you gonna say?
I was about to say it's mostly common on the abdominal
Yeah,
area.
it's a lot more common there for whatever reason, but it does happen where people get shingles breakout like on their face, and when that happens, that's considered like an emergency, and you need to go get that handled like right away. When it's like on your side or it's not an emergency, it's just kind of annoying. People say it itches, people say it stings, people say it hurts, kind of like chicken pox, but as long as it's not on your face or anywhere near your eye, it's not considered like an emergency. They're very similar to like the appearance of like the poison ivy, like they're vesicles, right? So they look a lot like, should I go back? They look a lot like this. These are vesicles. Anytime that thing's like a fluid-filled blister, it's called a vesicle, okay? So they look like that. They tend to ooze, and then they eventually scab over. All right, so here we go. Pain and burning, some tingling, maybe 2 to 3 days before the rash appears. They will be red, blistered, and then eventually they'll crust over and scab, okay? Diagnosis, again, a lot of it's going to be inspection, looking that it follows that dermatome pattern, that it doesn't cross the midline. You can actually like do a culture of this, or if you actually take like a little swab of the fluid, you can like look at it under a microscope and do a little culturing, and that can tell you what virus it is. But generally, they don't do this because they can just tell that it's shingles. Treatment for this, what do you think? It's a virus, so what do you think the treatment's going to be? An antiviral, right? And we know those end with vir, which makes it easy to remember because it's vir for virus. So acyclovir is a very common antivirus. Steroids also, just to help increase that inflammation. If it's super, super painful, they might even give you like shots of lidocaine, that numbing stuff they give you at the dentist. Just because some people have a lot of pain related to shingles, other people don't, so it's kind of a subjective experience. And then they also do have vaccines for it to prevent it, like we do for the flu shot and other things. They don't typically give it to you until you're older, because most people don't get shingles until they're like in their 50s, 60s type of age range. So none of you probably have had this. But Zostavax and Shingrix are the vaccines for prevention for shingles. Easy to remember because it has shing in it, shingles, and herpes zoster, it's got zoster right there.
I've had that.
Who said that?
Me.
You've had the vaccine? Prognosis for this is acute, so it's not chronic. You get it, it might last a couple weeks if you get the disease, and then it'll go away. It is contagious, so if you are around people that have it, try not to touch them, right, because it is contagious. All right, this is kind of a weird one.
After you get chickenpox, or
Yeah, you can. So it helps prevent you from having the outbreak of shingles again. So yeah, if you've had chickenpox, you won't get the chickenpox vaccine, but because you've already had it, right? And once you get chickenpox, you only get it once. It's not like you can get it multiple times. So there's no point in getting the vaccine after you've had the chickenpox, but you still can get the shingles vaccine.
It's a 2-dose.
She knows. Any questions about this one? I know it's kind of weird. Amanda, are you okay? All right. It is weird, but it also makes it easy to remember because it's different from everything. All right, now we're at impetigo. The cause of this one, this is a contagious bacterial infection. Okay? I think this is the first bacterial one we've talked about so far. I can't remember. Now there are various different types of bacteria, tons of different ones. The most common ones for impetigo are Staphylococcus or Streptococcus. You've probably heard of just a staph or strep, right? You heard of strep throat? That's a Streptococcus, but it's just in your throat instead of on your skin. And then you've ever heard of a staph infection, like for on your skin as well? That's caused by the Staphylococcus bacteria. Typically this is spread through like insect bites, so like mosquitoes, ticks, fleas, whatever, they bite you and they have the bacteria on them, right? And it's spread that way. And also people that just poor hygiene. Right? They're very common to have breakouts in daycares just because kids are nasty, right? They slobber on everything, they pick their nose, they touch everything, and they're just sharing germs with everyone, right? So impetigo is a pretty common thing that happens in daycares. So usually they'll like shut it down until everyone's better and then bring everyone back. These are also going to be vesicles, so they're going to be oozy, right? Kind of blistery. Usually they're around the mouth, but not always. They also form these pretty hallmark honey-colored crusts when they scab over. They literally look like dried honey kind of around.
Oh, yeah.
You've seen it?
Yeah.
Are you speaking from experience?
Yeah.
Okay.
Kind of understand.
This is what this looks like. So obviously this is like a
Yeah, that's what I'm saying. Like,
That's a kid. too.
yeah, I told you, kids are nasty.
I thought it was like ham and food.
Yeah, that's a different thing.
Oh god.
Yeah, that's a different thing. We're not going over that one today. Like I said, what we're going over is just like the tip of the iceberg. So
Oh goodness, I've never seen that before.
yeah, that's impetigo. A lot of this is also, again, just diagnosed with inspection. Anytime that there's a vesicle, right, with the fluid inside, you can do something called the Ch test if you're not sure. Like if someone has vesicles on their face, you might not know, did they get poison ivy on their face? Are they having shingles on their face? Or they have impetigo on their face, right? You can't always tell by looking necessarily, especially if it's kind of unclear. So the Ch test can be used on anything with a vesicle. Basically what they do is they take a little scalpel or like a little needle, basically to scrape some of the fluid out, right? Like pierce it so that the fluid can drain. And then they can take that fluid and culture it or look under a microscope to see exactly what's causing it, like what virus or what bacteria is causing it. Does that make sense? So a lot of the times they can just tell by looking, right? If it's like vesicles right here, I'm like, that's shingles, right? But sometimes it's unclear depending on like where it is or what it is, you know, so they don't always know. Treatment, well, it's caused by a bacteria, so what's the treatment going to be?
Antibacterial.
Antibiotic, antibacterial. Specifically mupirocin, this is like the most common thing they give. It's just an ointment. It's kind of like Neosporin cream, but like on steroids. I shouldn't say on steroids because I think I actually mean steroids. Like, I just mean like a lot stronger version of Neosporin. So mupirocin, yeah. Prognosis, this is acute. You get it, you get better, it's over. You don't have it forever. Yeah. All right. Let's see, what time is it? All right, cellulitis. And this is another bacterial infection with Streptococcus or Staphylococcus. These are the most common bacteria that affect the skin. So they'll see this all the time. Basically what happens, people get a small cut or, kind of break in the skin and the bacteria gets into the skin and starts releasing that toxic enzymes from the bacteria that causes this problem. A lot of times people get this after like a cat scratch because cat claws are very sharp, very deep, and then they also usually have a ton of like nasty stuff on their nails because they're in litter boxes and stuff. So cat scratches are like one of the major causes of cellulitis. Symptoms here, it's going to be very, very red, right? Erythema. Pitting edema. Anybody ever heard of pitting edema before?
Yeah.
I'll show you a picture here. This is what pitting edema looks like. So it's like the swelling is so bad if you press your finger into your skin, like it leaves an indent because of all that extra fluid. You did?
Really?
Yeah, people tend to get that in their legs when they're pregnant. It's just like that retention of fluid. It's like it's super swollen. And you press into it and it leaves an indentation. Okay. Let's see, where are we? The skin is usually very tender, kind of painful, hot. They'll even have sometimes these red streaks, which look like this. It's kind of a blurry picture. I'm sorry, I couldn't find anything that was better. But see, he has some kind of wound here that's infected, and you can see like the red streaking up the arm. That's kind of showing you that the infection is spreading in the vessels, right? So it's kind of like spreading up the arm. That's bad, right? We don't want streaking because that means the infection is getting spread, right? What else? Diagnosis is going to be usually just, you can tell by looking. They can do a blood culture if they're not sure, where they basically, a blood culture is they take a blood sample and they, grow it in a little petri dish and see what bacteria grows. Because it may be streptococcus or staphylococcus, but it isn't always. Some people have like a weird case of cellulitis, of some weird bacteria, and the treatment isn't working, and so they take a culture and they realize, oh, it's actually this bacteria, so we need to give you a different antibiotic, right? Because antibiotics are very specific to a specific bacteria. That's why there's 5 million different types of antibiotics, because they kill specific types of bacteria. So if you give the wrong antibiotic, it won't kill necessarily the bacteria you're trying to get. Does that make sense? This is usually acute. You get it, you get treatment, it gets better. Here's a kind of a picture of that redness and swelling of the legs. So this person is having kind of a cellulitis of the lower leg here.
That was me.
That's
It was really gross.
Did you have it with pregnancy?
Yeah.
Cellulitis?
Well, no, I just mean like
The swelling?
the pitting.
The pitting edema?
Like that.
Yeah. Yeah.
Couldn't that also look like a blood clot?
It could, but that's why there's lots of different tests you can do. If you have a blood clot, people can do other things to determine that. But we'll get to that when we get to cardio, so don't worry.
I was saying it's similar.
Yeah, the redness. Yeah. That's why another reason you do blood cultures, right? If it comes back clean, it's not cellulitis. All right, so now we're in I can't say this word. Dermatophytoses. Sure, I can't. This is an umbrella term, so there's different kinds within it. This is just basically saying it's a fungal infection, and they all going to start with tinea, right? All of the dermatophytoses start with tinea, and they're basically all the same thing. They're just named on their location. Okay, so if you have the fungal infection on your scalp, it's called tinea capitis, which is easy to remember because where do you wear caps? On your head, so that's easy to remember. On your body, it's called tinea corporis, and I don't know if this is well known or not, but corp, think of the word corpse and corporeal, they always mean like the body, right? So you see a corpse at someone's body. Another name for that is ringworm. That's like the common street name for it. Ever heard of ringworm?
Yeah.
A lot of people get confused by this name because they think it's a worm that's causing it. There are no worms involved in ringworm, okay? There's not a worm living in you. I don't know why they're calling it ringworm. That's very confusing. I don't know what that's about. It's just fungus on the surface of the skin. On the nails, if you have the tinea there, it's called tinea unguium. I don't have a cute way to remember that one. I don't know what unguium means. The other term for this that you might hear is onychomycosis. My husband just had this on one of his nails. It's very common in men for some reason. You ever seen like those old men and their nails are just very like thick, yellow, and gross? He had one of his toenails getting like this, and I was like, "You're getting taken care of right now. Like we are not."
Yeah, I'm with you. I just took mine last week, and it
Took
ended
what?
up, my boyfriend, his thumb was all jacked up.
Yeah, I don't know what it is, but it's more common in men for some reason.
He ended
But,
up
like,
having-
This is a very, very bad case,
Yeah.
right? Like this is very severe.
But yeah,
Stay
his
away
thumb,
from
his
me.
thumb looked like that.
Yeah, I was like, baby, I am not being married to someone with this feet.
Right.
You're getting this taken care of
Well,
right
they
now.
swapped Michael's, and he ended up having staph. So he had
Yeah.
like fungal
And bacterial.
staph,
Yeah. So sometimes you can have more than one thing going on at the same time,
Yeah, I
which
was like, how did you get?
I think it's because
How does that happen?
I mean
though?
men
Like,
don't take care of their nails.
Yeah.
You know what I'm saying?
Yeah, they do. No,
Sorry,
I'm having to
I
tell
don't
my
want to
husband.
attack.
No,
You're
you're right.
You're a little outnumbered here.
Yeah.
It's like they're scared to do.
I go down the room.
So, there are some men that do,
Yeah.
but generally
Generally.
speaking, they don't take care of their nails anywhere near the same way that women do, right?
Yeah.
So, the first time I saw his nails starting to get, I was like, "You're getting this taken care of right now." So this one has a specific treatment is terbinafine. You wouldn't use terbinafine for any of the others of these. because when it's in the nails, it's really hard for medicine to get to the nails, right? Because it's not like it's your skin. Like it takes a lot longer and a lot stronger medication to get into the nail beds than it would to get into just like your regular skin.
I don't know what she gave me, that myrrh, whatever, that for impetigo.
Merpearson?
Yeah,
Well,
she
that was for
gave-
the staph infection.
Yeah, and then
Mhm.
she gave him some kind of fungal medicine.
Yeah.
So I'm wondering if that's not the
Yeah, I mean there are tons.
generic brand.
We'll get to
Yeah.
more antifungals at the end when I go over the medications.
Okay.
You have a question?
Yes.
You can just go. Yeah, so terbinafine, this one is, like I said, specific for the nails. It is an oral pill that you take, and you have to take it for like 3 months
Oh.
before it before it fixes the problem. Just because, like I said, it takes a long time for that medication to get into the nail beds, right? Because it doesn't have you don't
So
have
is
blood
it like
vessels.
You have to take it so it gets in and it absorbs from the inside?
Yeah, like you can use like the creams, but it doesn't work nearly as well, and it takes much longer. Like they told my husband, like you can do the creams, but you're gonna have to do it like multiple times a day for like 6 months. It's like, or you can just take the pill once a day for 3 months. And so it was like we did that.
That's a lot.
Yeah, but I was like, we're not having those nails, so you're gonna pick one. Anyways, in the feet, and this is specifically like between the toes, not the nails, right? So the skin of the feet is called tinea pedis, and you can remember ped like, you know, a pedicure, ped. The street name for that is athlete's foot, right? It's the, let me see. This is what athlete's foot looks like. You know, you get the fungus in between your toes.
That is crazy.
Yeah. Again, this is more common in men, especially people that do sports. That's why they call it athlete's foot, because they tend to sweat in their shoes. You know, they run around with sweaty socks and stuff. So that's just, again, stereotype tends to
You would
happen.
think they would.
That
Be
person was
taken-
even trimming their nails.
You would think they would be taking care of their feet and all that more because.
Again, generally speaking, men and hygiene is not the same as women. There are exceptions. You look very clean. You look very presentable today.
I'm good.
I'm just saying, largely speaking,
None
right?
of this. Gross.
And then lastly, again, sorry, this is gonna be more common in men too. In the groin, they have tinea curis, which is jock itch. You ever heard of jock itch? Again, this is specifically, they call it jock itch because it's mostly like guys in sports because they have to wear those cups, you know, and so it kind of creates like a lot of sweaty kind of moisture in that area. Women don't wear cups because we don't need to, right? So they tend to happen in more often in guys. I did not put a picture of that in the PowerPoint.
Yeah, I was like, I just.
But there is one in the book, so
Okay.
you can see that there. It's just very red and kind of yeasty looking in the groin area, okay? So it's all the same thing. It's all tinea, which is the name of the fungus, is tinea, right? And then it's just literally named off of where it is on the body. Does that make sense? So the treatment is all going to be the same because it's all the same thing, except for the nails, just because you need something stronger to get into the nail beds. And we'll talk about more specifics on medications at the end. The other thing is that fungus, they really like warm, wet environments, like sweat and like things that are like, you know, in the feet, because you have shoes on all day, you don't get like airflow and sunlight, right? So if you want fungus to get better, you keep the area clean, cool, and dry and exposed to the air, and that kills fungus off pretty quick. This is ringworm, by the way. They call it ring because it's like literally in a circle, and there usually is like a darker ring. You can see how this part is redder than the middle. So they call it ring. I don't know where they picked worm for. Literally people think, oh, I have a parasite. Like, no, there's no worms involved. Don't worry. All right, decubitus ulcers. This is probably something, Tina, that you're probably familiar with being a PCT, is bed sores. Anybody ever works in a like a skilled nursing facility or like a retirement home with old people? Bed sores are real common, unfortunately. I don't want to say it's all because of negligence, but a lot of the times it is, where people aren't doing what they're supposed to do, and people are laying in bed too long, and like,
Crazy.
you know how like if you sit on your butt too long, your butt can go numb. So it's basically that, like, but worse. So, like these little ladies, especially that are like laying on their backs on their bed all day, and all that weight is on their tailbone, and so they start getting sores on their you know, like right there, the base of their spine, because they're not getting people out, helping them get out of bed or turning them back and forth. So this happens a lot in facilities like that because there's just usually too many patients and not enough workers to kind of prevent that. We also call them bed sores or pressure sores or ulcers, right? So basically what's happening here is that it's chronic lack of blood flow because of that pressure, right? Like you're sitting, it's kind of like when something goes numb, like you sit on your foot and your foot goes to sleep because you're blocking the blood flow to that area. So just imagine that like for hours and hours and hours a day.
Like that tingling.
Yeah, it's like, but eventually it's going to stop tingling because that area is going to start to die, right? Like if you have reduced blood flow to an area of the body for too long, like that part of the body is going to die, right? So it tends to occur, like I said, in people that have a hard time getting up, so immobilized people in nursing homes, people that are like in the hospital on a ventilator and can't move and are dependent on other people to move them, right? So this happens a lot there. The symptoms, it kind of depends on how bad it is. So we have everything from a stage 1 to a stage 4 pressure sore. Stage 1 is the least bad, and stage 4 is really bad. I'm going to show you a picture. So this is a diagram. So stage 1 is just the first layer of skin that's been affected. If it isn't addressed, it can keep getting worse, like ultimately a stage 2, which now goes into the second layer of skin. So the epidermis is the first layer, dermis is the second layer. Stage 3 is in the third layer, the hypodermis, which is where a lot of the fatty cushion is. And then stage 4, it can go all the way down to the bone. Okay? And that's obviously that's really bad. It takes a long time to heal. Here's some not yet. Yeah, here's some pictures. So stage 1 is just kind of redness, it's just like, it kind of might look like sunburn a little bit, just like a very reddened area. Stage 2, you can see that it's like, the first layer of skin is broken through, kind of like a skin's knee.
So are these like burns then?
They're not burns, they just kind of look like them.
I just mean like for like how they would heal, as in like scar or things like that.
I mean, probably the first 2 probably wouldn't scar too bad, but once you get into like stage 3 and 4, they're gonna have a nasty looking.
Yeah.
Especially like this. See, this is that white stuff is the bone.
Right.
This is someone's tailbone, I think, probably. That's probably like their tailbone right there, where it's like the pressure was so bad it just got all the way down to the bone. So these obviously are going to take a really long time to heal, and it's very sad. So back to the symptoms, like depending on how deep it is. So like the early stages, like they're going to have like shiny reddened skin. And they typically are over areas of like bony prominences. So like anytime there's like a sharp bone underneath, like on your butt bone or like on your heels, because like if you're laying in bed, you know how like your heels are resting on the bed, and if they're just laying there constantly, that heel bone's going to be pressing into your skin. Later on, you might see some blisters, some necrotic tissue. Remember what's necrotic tissue mean? And that was I think in our dead. So like blackened area, dead skin, ulcers. You just diagnose it by looking at it, visual exam. The treatment for this is let's try to prevent it from happening in the first place. So turning patients, not letting them sit in one position for too long. They have special wound care professionals, nurses, and doctors that specialize in wound care. And antibiotics just to prevent infection, right? Because you have like this big open area of skin, that's just asking for bacteria to come in and get infected. You really don't want to have an infection on top of all this healing to try and do, because then it gets really bad. And if I have seen people that get such bad, bed sores, like stage 4 all the way down to the bone, they get a massive infection, and then the infection gets into the bloodstream, they go septic, and then they die. So it can be fatal if it's not taken care of. But there is obviously, just like any injury, eventually it heals when you get treatment, right? All right. Hope nobody is squeamish in this class because of the pictures. All right, this one is going to be different because this one, scabies and pediculosis, this is actually like a infestation of like bugs, right? So it's not like really a skin issue technically. Anybody heard of scabies before?
Yeah.
You keep saying yeah, like you've experienced it.
I'm from Florida. No, I've seen it.
My husband's had scabies before. He was in the military, And he lived in, like in some barracks and stuff with like close quarters and stuff get spread easily. He said scabies was the worst thing he's ever had in his life because it was like so itchy he wanted to like peel his skin off. I kind of put scabies and lice into the same slide. Pediculosis, that's the fancy name for lice. And scabies tend to be like on the body, whereas lice tend to be more in the hair, right on your scalp. So scabies, their technical name is Sarcoptes scabii. They're an itch mite. Let me show you a picture of what they look like. This is what a scabie looks like on like blown up 1,000,000 times under a microscope.
Oh my god.
A little creepy, isn't it? Obviously, you can't see that with the naked eye. They're like too tiny for you to actually see. But basically what happens is the scabies, like they bite and burrow under your skin. And as they like are burrowing, chewing through your skin, it itches so bad and it like you just want to scratch and it's the worst thing ever. Typically, for some reason, they tend to like being in the webs of the fingers. So like you see that there, that's pretty much like a guarantee that it's scabies. Now it can be on other parts of the body, especially if it's like you have a really bad case, like a really bad infection. But typically, like most often, they show up like in the webbing of the fingers, and then you'll just see like these dots, like which is basically following the trail of them burrowing under the skin, and it's extremely, extremely itchy. So you can see here.
It's almost like, what is that,
A bed bug?
no, what's the ones that you get out when you're outside?
Ticks,
Oh,
fleas,
Ticks. Chiggers. It's
Chiggers.
almost like chiggers.
Yeah, so there's fleas, bed bugs,
Yeah.
ticks. I just told you there's a lot of skin stuff. I'm just trying
Well,
to.
chiggers does the same thing. It
Yeah.
like burrows in like cracks and crevices, and,
Yeah.
and they itch to high heaven.
Yes.
I've had chiggers because we just go hunting.
Yeah.
See, and yeah, they're awful.
Yeah.
I think I'd rather have 500 million ticks than.
Oh yeah, because ticks you can like at least see and take off, whereas this you can't.
They got Lyme disease.
Lyme disease.
Not every tick gives you Lyme disease, right?
More, so.
Huh?
I think up north more so, but yeah, here.
It's only certain ticks if they're infected. It's like not all raccoons have rabies. It's just if the animal has rabies. So
I remember when we was working at Sonoma and okay, I'll forgive me. Okay, but I used to work in registration in the ER, okay? So when somebody come in, we were in what? Oh, no, ain't going to that room. I'm like, ain't going to that room.
that's funny. Yeah, especially because scabies are very highly contagious. They're spread by close contact. So like sharing, towels or blankets or clothes or hairbrushes with people. It tends to happen a lot in overcrowded areas. So like if you're like in, dorms or like barracks where there's a bunch of people together, close contact is kind of unavoidable. So there tends to be like outbreaks. This is for scabies and lice both. They both are pretty contagious. And yeah, pediculosis, that's the name for lice. And depending on where it's located, it has a different name. So pediculus humanus capitis, again, cap is for which part of the body? The head. Corporus, what part of the body? Yeah, just the body in general. And then pubis is going to be like in the pubic hair. Okay, so you can get lice there as well. Anywhere that there's hair, they like to be. Especially because they like to lay their eggs there, because the eggs can stick to the hair follicles. Symptoms, like I said, scabies, super itching. It tends to be worse at night. For some reason, the itch mites, they're a lot more active at night. They do a lot of their burrowing at night. So it makes it very difficult to sleep. You'll feel that sensation of crawling like under your skin, which is very unpleasant. Lice, the pediculosis, you'll see like the nits is what they call the eggs, like on the hair shafts. You can even maybe see them in the bedding as well. So I showed you scabies. This is what lice look like. This is obviously a very, very bad case, but you can see these are the, these white things are the eggs.
Oh.
I hope nobody was squeamish, right? So this is kind of showing you like the nits wrap around the hair follicles and hold on. That's what you're seeing there.
So like you just can't wash your hair and like it just.
You can. I mean, it just the washing your hair doesn't like get it out.
You have to go to
Crazy.
you have to go to a salon that
Yeah.
especially
Yeah.
does.
So kind of a misconception is that people that don't wash their hair get lice. That's not
Oh,
actually
so
true.
that's
Yeah.
yeah. That's
So
not. Okay.
It's just they just get exposed to a lice and it just starts laying eggs, and it doesn't matter if you're washing your hair or not. It doesn't get rid of it. You have to use special lice shampoo.
Yes.
Grace?
When we lived in England,
Oh,
We lived on a military base, but the kids
Oh.
across the street,
me
they went
too.
to English schools,
Uh-huh.
British school. And I'm not kidding you, it was like maybe every other week they would come home with lice.
That's weird. I don't know where they keep getting it from. Because if once everybody is treated, usually,
Yeah.
Yeah.
It just
unless they're
kept
just not.
They're just not treating.
Well, because what can happen is if you treat the like on your head, but you don't like treat your blankets and towels, you
That's-
can get
Oh,
reinfected.
okay, yeah.
So, yeah, it's a misconception that you get it when you don't wash your hair. It's not related to that. So, yeah, not pleasant. Any question? Oh wait, I didn't go over treatment. So for lice, there's a special shampoo you have to use. It actually like kills the eggs and the lice. It's called permethrin. And there's the same thing for scabies too. It's just permethrin, but it's a cream, right? So you'll put the cream all over your body versus the shampoo in your hair. Okay. And again, you can't just treat just your body. You have to treat like your towels, your linens, your bedding. So you have to like put everything in the wash, put it on high heat. You know, make sure that the high heat kills it, right? Just shampoo the carpets. It's a very in-depth process.
They
Right.
sell like sprays that you.
Yeah, there's like house bombs that you can release and stuff. They do that for like fleas and stuff too. But that could be why they kept getting reinfected if they didn't like completely eradicate everything else. So
That, or if they think, if there's multiple people and, they like say, oh, I don't have it, they're the only ones that's got it, and not everybody
Yeah.
gets treated.
So it's annoying. All right, so now we're at like the growths, tumors and stuff. Also, just quick question. I'd like to ask: do you guys want to take a break, or would you rather just me keep going? And just if you want to get up, just go. I don't know how you guys feeling. Let's see. Let me see how many. Let me see how much more we have. Okay. You guys want to take a break before we keep going?
Yeah.
Well, like a 10-minute break.
Yeah.
All right, go ahead and do that. I usually like to try and take a break around the hour mark, you know, but
That's what
sometimes
Miss Kelly does.
some people are just like, no, just keep going. So
She usually gives us a break.
I'll take a break when you're done.
anybody have any questions or anything while we're breaking?
I took that test, I used my notes, but I didn't know, I forgot to ask you if that was okay.
What are you talking about?
The immune test,
The quiz?
yeah, I took it, quiz.
Uh-huh.
I wasn't sure if I took it this morning because I was like, oh shoot, I bet that's due today. So I took it this morning, but then I thought afterwards, I was probably not supposed to do that.
No, it's open note.
Okay, so I'm allowed to do it at home if I miss.
Yeah, you're supposed to.
Okay, good.
Yeah.
Okay, good.
Because if you're not in class, you can't do it in class.
So I didn't know if you were like one of those teachers that you wanted us to sit in here and do it.
No, it's a quiz. It's an open note quiz. So people do it in class. They use their books, their PowerPoints, their notes that they take now. So
Yeah.
if you are home and you watch the lecture, it's the same thing.
Okay.
I mean, for exams, obviously, that's different.
Yeah, I just didn't know because I know I've had some teachers in the past that have been like, I need to see you do it.
I mean, if it was a closed note quiz, then sure, but I make an open note. 'Cause I'm just trying to gauge how much of the material people are getting, right? Like immediately after hearing it. Because if like everybody got the same question wrong, that would tell me I need to go back and go over that again. You know what I mean?
Yeah.
So.
Oh, this medical stuff is nasty. Oh my goodness.
Welcome to diseases.
Oh my god. Skip this part.
Sorry.
Oh god.
I don't know how to pause this, so I was just gonna have an awkwardly long break right in the middle of lecture. Sorry. I'll just skip through that. Because I have to do it as like a YouTube live, because my phone memory can't do a 2-hour video. So I have to do live streaming, and then you can't pause in the middle of a live stream. So.
You can midway put in like the comments like there will be a bit of a break in between
Yeah.
at like 2:06 and it'll end around this time.
Well, she had you have like over like 3,000 followers on there. So
I've had my YouTube channel for a while. When I was in nursing school, I would do a lot of tutoring, and I'd always record those. And
That's what I was gonna say. I bet a lot of people follow you
just for medical stuff,
yeah.
because they can technically test these lectures too, so I can still getting it for free.
Yeah, I was laughing my butt off when I found that channel. I was like, I know that voice. That's Amanda in the background. They're on YouTube. Oh my gosh.
I don't know how to do it any different, but I don't ever put anybody's faces in there.
Yeah.
It's just the screen, PowerPoint screen.
Yeah, at one point when I was watching, I was like, is it frozen? It stopped moving. Yeah, it was just, I think y'all were working on like one page or something. It was taking a while. Then it froze.
That's the other thing, is that if there's any like Wi-Fi interruptions, it causes some problems, but like I literally can't take a 2-hour video on my
The
camera.
Wi-Fi here horrible.
Yes. That's why I do not use it.
It's so slow.
This looks super itchy.
It's not.
It does like, I would kind of pick at it.
Yeah. A lot of people, old people have those.
Yeah.
It's
The,
kind of just cosmetic.
does it hurt?
No,
No,
just like
it's just
ugly
there.
moles, kind of.
Yeah. Is it hard or is this
What's it say?
rough? Like, ew.
Yeah, they're real common in older people. People get all sorts of weird skin stuff when they get older.
Yeah, we had this one resident, she had like a growth, and they were like, we don't know why it's growing, but it just keeps growing. Then once she found it, she ripped it. She was one of those ladies, she didn't know where she's at, but she's always talking to herself. Yeah, she heard talking there like, it won't stop bleeding, we don't know what to do.
Hey, don't touch it.
It looked like, literally, it looked like a stick coming out, like, because that's how rigid it was.
Yeah, dermatology is a wild thing to get into. I am one of those weirdos though that enjoy watching like pimple popping videos. So
That's my mom.
I like listen. If I could do that job, I'd be so happy. I'd be like,
I did do that job.
huh?
So I went to esthetician school.
Oh gosh, I would love to do that. Like, I will pay you to let me do this. Actually, you don't even need to pay me. Like,
So what? So where do you practice then?
I have like 4 jobs. This is one of them. You mean with my nurse practitioner? So I actually do something called at-home risk assessments. So I actually get to drive around to people's houses and kind of do like a primary care visit in their home versus them coming to an office, which I like a lot better because it's different every day and I can make my own hours, which is chef's kiss. Like, I don't want to go to the same office 8 to 5 every day. I would literally go insane. So it's I can also do it part-time. So whereas usually when you work something like that, you have to do Monday through Friday.
The benign and pre-malignant tumors.
So it's kind of like a home health.
Similar, yeah.
Oh, okay.
Is this everybody?
I think so.
Yeah,
What is-
I think I was trying to, I think it's 11.
Are we missing anyone? I don't want to start without them. Okay, let us resume. Sorry for that awkward break if you're watching this lecture. All right, so now we're in growths what we call benign and pre-malignant tumors. Pre-malignant just means precancerous, right? So some things can be precancerous. So the list of benign ones, which we'll get into, there's the seborrheic keratosis, dermatofibroma, keloids, cysts, blah, blah, blah. And then the only one that we're going to talk about that's pre-malignant here is the actinic keratosis. So let's go ahead and start. This is the picture's covering the word. Shouldn't be there. Seborrheic keratosis. These are just weird looking mole-like growths. They're very common in like the elderly. They're benign, even though they just look weird. They tend to be like dark brown, tan, even black or yellow. They're kind of greasy a little bit, like when you touch them. They can be anywhere in the body. They're often like on the trunk and arms though. They're just kind of rough, wart-like. They're raised, and they're just more of a cosmetic issue than anything. They're completely harmless. Okay, so that's what that one is. There's really no treatment because there's nothing wrong. It doesn't hurt. It doesn't itch. It's not making you sick. It's not an infection. So it's just a cosmetic issue. So you can have it removed if you want to, but you don't have to. It's not going to hurt you to have it. But a lot of people obviously will see this and freak out if they have something super wrong with them, and that brings them to the dermatologist. All right, this one is just like a weird little bump. This one actually is your body's reaction to like a viral. Usually if like you get an insect bite, your body can react and form one of these. It's a scaly, they're usually pretty hard, they're slightly raised. They're very common on the legs just because bugs tend to bite there. But again, it's completely harmless. You don't need any type of treatment for it or anything. Keloids. Now, have anybody ever heard of these or seen anyone with these? They do tend to be more common in darker skinned individuals because they have more melanin. And so the melanocytes are the part of the skin that are responsible for the pigment. For some reason, they tend to cause this. So for hypertrophic, that just means excessive growth. Okay, so hyper is too much, right? Hypo is not enough. So hypertrophic is excessive growth of scar tissue. So this is probably from when they got their ears pierced, right? You got your ears pierced and then it's trying to heal itself and it's creating all this excessive scar tissue that's not necessary. Okay, so it can happen from surgery or trauma, like any type of cut in the skin when you have to get a scar. It can like produce more scar than it's necessary. Obviously, it's noticeably larger and thicker than the surrounding skin. There's really not much you can do other than like either get it surgically removed or steroid injections, right, which will help to decrease that inflammation. But they typically tend to come back. Like if you're someone that gets keloids, if you get it surgically removed, well, now you have another wound to heal, right? So then it's more likely to just get big again. So a lot of times they just cut them off, and then like when they slowly grow back, and they cut them off, and they kind of slowly get back. So it's not like they go away forever. You just kind of have to manage it. So
I wonder if it like hurts.
I don't think it hurts. It's just kind of a cosmetic issue, right? So people will cut them off when they get to be annoying or not visually appealing. Yeah. That's mostly what the ones I'm talking about so far. Most of these are just cosmetic issues, right? There's nothing wrong with them in the sense that they're not going to hurt you, right? They're not an infection, they're not inflammation, they're not cancer. They're just a eyesore type thing.
Could be mentally too.
Huh?
Could be emotionally.
Oh, for sure. Well, and body image, all of these things can be body image issues. So the keloids or like, these things, if you have a bunch of these growing, like if it's on your face, that's not going to look good,
Yeah. My sister had one on her neck.
The keloid?
Yeah, because she had a thing with her. Yeah, she had surgery with
Yeah.
her. Yeah.
Yeah. It's pretty common.
My brain, I don't know.
All right, here's another one. I don't know why the pictures are covering up the words because on my PowerPoint it's not at home. That's weird. So this is an epidermal cyst or a sebaceous cyst. This is basically like, those big pus, like big pimples essentially, right? There's like these little glands that slowly fill with fluid and pus. They usually don't hurt, even though they look like they should. They're usually painless. They can burst spontaneously sometimes, or you can manually drain them to get the foul-smelling pus out. If they do surgery to remove them, obviously they'll just give you some antibiotics to prevent an infection. But again, they're not harmful. They're just kind of, not the greatest thing to have. My dog, for whatever reason, gets these so bad, like all over her, and it drives me nuts because, like, I was telling this to people before. I'm one of those weirdos that like to watch those pimple popping videos, and I love that. Like, that would be like my dream job to do that. And I want to get them off of my dog so bad, just to, like, drain them and clean. I would love it, but she gets so freaked out, and like she won't let me, and it makes me so. Because it's just like I can see them. I want to get them.
Complete opposite. I don't like.
I love that stuff. Ever since I was a kid, I've loved doing popping my brother's pimples and like cleaning my dad's toenails. I know people think that's disgusting.
Yeah. Oh my
I just like that. I'm sorry.
Toenails?
I don't know.
Listen, I just like, I don't know, there's something satisfying about cleaning it and making it nice.
Just make it nice.
Yeah, I know you take something like that was gross and you clean it.
Yeah.
It's people like cleaning, but I don't like cleaning toilets. I like cleaning nails. Anyway, enough about me. Back to this. Okay, so this is a skin tag. Medical name for that is an acrocordon. Okay. Anybody ever had one of these? I had one of these, like, it was really awkward, like right in my armpit. So like every time I tried to shave my armpits, it would be really hard to like not cut myself on the razor with one of those. It was small.
Yeah, I was gonna say it wasn't as big as that.
No, it was small, but it was like just enough that it would like get stuck in my razor and it would hurt so bad. So I had them freeze it off with the cryosurgery. It didn't hurt hardly at all.
See, mine comes and goes. Like it doesn't it's not.
So you can tie it up with dental floss.
It's weird.
Tired?
Oh my goodness.
You can. It's kind of like when they do with your eyebrows with the string.
Threading.
But I'd rather do the freezing thing. So these are often caused by friction. So like they tend to be in areas where there's a lot of friction. So the armpit's really common because there's a lot of like rubbing because it's like the skin is just getting rubbed and it gets irritated and makes these skin tags, which could be why it flares up for you like when you have more friction, I guess. So armpit's really common. Axilla is the medical term for armpit, FYI. They can be, whatever skin color your skin is. They have they're attached with a short little stalk, and so like I said, you could tie like dental floss around it. I feel like that would hurt though, because it takes a while to cut off the blood circulation. But whereas the cryosurgery, like the freezing is just instant. But yeah, there's nothing wrong with them. It's just a cosmetic issue. But for me, it was just annoying because of like where it was. It was hard to shave. All right, so then we're at the actinic keratoses. These are actually the precancerous ones, but they don't look like much, so a lot of times they get ignored. Like, compare this to, like, the one we saw up here. Like, which one looks scarier, right? Like, this one looks more concerning. You're like, oh, surely this is something wrong, right? But that's completely fine. Whereas this guy down here, the actinic keratosis, this is actually precancerous, but most people wouldn't think anything of it, right? You'll often find these on sun-exposed areas, so like the face is a big one because people, their face is exposed all the time. People don't wear sunscreen, especially like truck drivers. They sit and the sun comes through the window all day and they're just getting sun on their face a lot. So long-term UV radiation causes these. So you can see it's kind of like a reddish area of rough skin with this yellowish crust on it. And that's what an actinic keratoses are. These are precancerous, so if you don't get them addressed, they can turn into something worse. So they usually remove these with, freezing them off. If they're pretty, like, if you catch it early, you can freeze them off and it's fine. But when they get more progressive, then you're gonna have to do like more invasive surgeries. All right, so once it becomes full-blown like skin cancer, we've got 3 different types of skin cancers, and you might have heard of these before. You ever heard of basal cell carcinoma, squamous cell carcinoma, and melanoma? So those are the 3 skin cancers. Melanoma is by far the most severe and the most invasive of the 3. Squamous cell and basal cell are usually very easily treated. So what causes this is obviously just UV rays damage. It damages your DNA of the skin. Risk factors, so people that have lighter colored hair and eyes and skin obviously are more at risk, right? When you have darker skin, the melanin protects you from the UV, right? Obviously, people that have darker skin can get skin cancer. It's just less likely, right? So they have to have more exposure than someone with lighter skin because the melanin is protective, whereas people that are lighter skin don't have that protection, right? So like redheads tend to have very, very pale skin. They're going to be the most at risk for getting skin cancer, okay? So again, these are most common in areas that are sun exposed. So the face is a big one because people don't walk around with their face covered all the time, right? Whereas like the rest of the body usually has clothes on it, so you're less likely to have them there. So the hands are another one that's often exposed, like people that work outside, you know, gardeners or landscapers. The face and the hands often get these. Tops of the shoulders, you know, like when you wear tank tops, you know, the tops of the shoulders get real burned. So areas like that. So with basal cell and squamous cell, let me show you a picture what they look like. So basal cell is more like round and domed, and squamous cell is more like an ulcer. So I don't know what's going on out there.
Nope, it's open.
I know, right?
Yeah, so basal cells look like a shiny bump, like maybe pearly white. That's usually the basal cell. The squamous cell usually has like an ulcer, kind of like an indent in the middle, and it will like go through, it'll heal and then get worse again, heal and get worse again. So that's where it's a repetition of ulceration and healing. Diagnosis is usually, you know, a dermatologist will look at it and inspect it. They can do a biopsy, right? We talked about what a biopsy is, where you insert a needle, pull out some cells to see if this is just like a regular mole, if it's just a regular wound, or if they're actual cancer cells, right? And then if it is cancer cells, here we have that Mohs surgery I was talking about. So like, you think this is the only part where it is, but this is just the surface, right? You know how there's multiple layers of skin, right? So this could be only what's showing up on the top layer, and there could be like a whole iceberg or like network underneath the skin. So you can't just cut out just that part and be done with it. You cut out that part, and then like, you know, you have to take extra skin around, and if all the extra skin around comes back healthy, then they're like, okay, we got it. But if they take extra skin around and there's like, oh, there's more cancer over here, they have to keep cutting until everything comes back clean. So oftentimes people will think, oh, I just have a tiny skin cancer, they're just going to remove that, and they end up having to take like half the skin around the hand. See what I'm saying? So it's like usually a lot worse than what they think, because it tunnels under the skin in like these offshoots, like kind of like octopus arms, and so you have to just keep cutting because you get it all. Because if you don't get it all, it's just going to keep spreading and pop up other parts of the skin, right? So that makes it difficult, and people, you know, it's difficult, like it's on the face, for example, and you have to like cut off a lot of skin, and you have to get like some plastics to make it look better. So that's what's difficult about the skin cancer removal. You can do, you know, like if you catch it early, you know, and it hasn't spread a ton under the skin yet, you can do the cryosurgery or the electrodesiccation, or the freezing and the burning, right? Radiation therapy, you know, like chemoradiation type thing. Prognosis, so again, the outlook of this, so when it gets treated, they always do prognosis with cancers in 5-year survival rates. So the survival rate is 95%. So very high survival rate, which is good, right? It's not one of the deadly cancers. In comparison with the melanoma, right? Melanoma is different. Melanoma is not the same as basal cell or squamous cell. This one's more serious. Again, you kind of have the same kind of risk factors though. People that have light skin, light hair, sun sensitive, a lot of skin exposure, lots of histories of getting severe sunburns. So the problem with sunburn isn't just that it hurts, it's that you're increasing your risk for melanoma every time you get sunburns. So people that live close to the equator obviously tend to have more of this than people that live in areas far away from the equator who don't have a lot of sun exposure. Tanning beds is a big one. People think, oh, it's just this, you know, getting a sunburn. It's like, no, like that increases your risk for melanoma every time you use one. They have something called the ABCDs, or ABCDEs of melanoma, to kind of diagnose and figure out if something is likely to be cancerous or not. I'll show you a picture here. So you see A, B, C, D. They didn't include E. I'll tell you what that one is. So typically, if you have like a weird mole or something, you can kind of tell if it's normal or if it's melanoma based on the ABCDEs. So the first one is asymmetry. So you can see that this one is like almost perfectly round. So that's pretty symmetrical, so that's normal. Whereas if it's like asymmetrical, you can see how this one's kind of like a random shape. That's more likely to be melanoma, okay? Then we have border. So you see how like this one, like the edges are smooth, right? The like going around it. Even though this one is asymmetrical, see it's not perfectly round, but the borders are smooth, whereas this one's borders like are all like not smooth and jagged. Okay, then we have color. So this one is all one color. This is all like a kind of brownish color, whereas this one has multiple colors, right? So multiple colors more likely to be melanoma. Then we have diameter. So if it's smaller than, 1/4 of an inch, it's most likely normal. But if it's greater than 1/4 of an inch, like it's the size, it's more likely to be melanoma. And then the E, I don't know why they didn't include E, but E is evolving. So if it's like changing over time, it's more likely to be melanoma versus like, oh, I've had this on me since I was born and it's been the same way for 30 years. It's like, that's probably normal, even if it looks weird. But if it's been like, oh, this looks like this 2 years ago and now it looks like this, that's evolving, okay? Does that make sense? So those are the ABCDEs of melanoma detection. Everyone go home and look at your moles in the mirror when you get home and look at those. Diagnosis is through biopsy, right, to see if it's cancerous or not. If it does come back as cancer, they'll probably want to do some imaging. You guys know what metastasis is? Spreading. So you know how like you can get cancer in one spot and then the cancer gets, into your body or into your bloodstream and travels somewhere else? Those are called metastases. So they'll usually do like a CT scan or whatever to see if the cancer has spread to somewhere else, okay? With treatment for this, complete excision. Excision just means removal. Like that's the fancy term for like a surgical removal. With the Mohs surgery, they'll also probably want to do chemotherapy as well because melanoma is very invasive and very severe. Because if you look at it seems like similar, but a 5% decrease in survivability is pretty significant. So it went from 95 to 90, which still sounds good, but that's still worse than the other ones. All right, now we're going to talk about abnormal pigmentations. So all of this has to do with the melanocytes. I kind of talked about the melanocytes a little bit ago that do different things. So anything that ends with cyte is referring to a cell. And so a melano is referring to melanin. So it's the cells that are responsible for secreting melanin, which is the pigment, right? Which determines how dark your skin is. So something is going on with the melanocytes where they're like malfunctioning, okay? All of these are benign. There's no problem that needs to be fixed. It's mostly just cosmetic, okay? So there's various disorders. You've got albinism, vitiligo, melasma, hemangiomas, all the rest of them. Okay, so let's start with albinism. You've probably heard of people that are albino. Yeah, so this is where they just don't have melanin at all. Like they have no melanin. Their melanocytes just can't do it. So you have very, very pale skin and like white hair. And for some reason they tend to have either like blue or pink eyes. And sometimes you get one of each. It's very interesting looking. Not super common, but that's just what's happening is that there's just an inability to produce melanin of any kind. Now we have vitiligo, which is where you do have the ability to produce melanin, but for some reason they start losing the ability. You know how like obviously your skin replaces itself constantly, that's why you have like dead skin cells that constantly flake off, so your skin is constantly being replenished and renewed. So it's like it starts being patchy like this because as your skin cells are being replenished, they stop. For some reason, some of them lose the ability to start producing melanin, so the ones that are being replaced just lack melanin. Does that make sense? So this can affect both white people or black people, anybody, right? So you can see the top one is someone with darker skin versus on this bottom picture of someone who's like lighter skin. You can see they're both lacking melanin. Just the top one is just more noticeable just because of the comparison. And I don't specifically know, but you know how Michael Jackson had his skin colors changing. Sometimes people say that it was an extreme form of vitiligo. Others say that he purposely did it with bleach. I don't know. Yeah, so I don't know. I really don't know. It doesn't matter, but that's just an example of like you're losing the ability to produce the melanin.
I went to school with a girl that had.
I thought you were about to say you went to school with Michael Jackson.
No, seriously. I went to school with a girl who had this.
Yeah. The reason why there's like question is because usually it doesn't do the whole body, right? It's usually just very patchy, you know, so that's why there's like this stuff about it, but I don't really care. There is question whether or not it's possibly autoimmune, right? Because they're theorizing that the body is attacking the melanocytes, right? Like just like any other autoimmune disease, as they start attacking those melanocytes and eventually stop being able to produce the melanin. So we don't really know yet, but they're considering that's probably likely that it's an autoimmune disease.
I was about to say, so if somebody did not have that, and then all of a sudden started having that, would that not, and they also have an autoimmune, would that not kind of coincide?
I have no idea what you just asked.
I have a friend that she's tan, never had any problems whatsoever, and then all of a sudden her body started doing that.
Yeah, that's what happened. I mean, it happens later on in life. It doesn't, like, because obviously you have the ability to create
Yeah.
melanin, and that's why you're, like, slowly losing it. So it's they don't know, but they're thinking it's autoimmune, where it's like, it just kind of one day flares up and you just
I know
start.
she also had an autoimmune disorder.
Oh, well, people, like I said before, if you have an autoimmune
Yeah.
disease, you're more likely to have more than one.
Okay,
So-
so I was about to say, because I know she didn't have that before.
Yeah. Okay, now melasma, this one tends to happen with hormonal changes. So a lot of times people get it when they're pregnant or if they're taking birth control pills because that affects the hormones. Right, so what it does is it just causes some darker patches of skin to appear on the face. And it's not permanent because, again, like I said, the skin is constantly replacing itself. So kind of like a skin tan doesn't last forever. Eventually, it goes away, right? So it just takes some months. Like usually people, after they give birth and their hormones regulate, it'll go back to normal. It just takes time. So this isn't like necessarily permanent. Or some people, they stop taking their contraceptives and then it goes back to normal. So this is just an excess of melanin, right? Instead of it losing the ability to make melanin, they're creating more in spotches. And since it occurs in women, there's got to be some relation to estrogen, you know, because that's the most common, like we have more estrogen than men do. Men do have estrogen, but not as much as women do, estrogen, progesterone, and all those things. So I don't know all the details of that, so you guys don't need to either, but that's just why. Okay, hemangiomas. These actually are related to blood vessels. So like you'll see that there's like a blood vessel just starts randomly producing a bunch more offshoots of blood to an area. So you have like a bunch of blood flow, like unnecessary blood flow in a part of the skin. And it can be red, blue, or purple, because sometimes the blood can look blue under the skin, like on your veins and things. They call these hemangiomas, again, heme. What does that mean? And yeah, so anything with heme is referring to blood. There's 3 types. There's cherry hemangiomas, strawberry hemangiomas, and we call a port wine stain. So cherry are just the smaller ones. They're like really round and like kind of small. Strawberries are like they're bigger and they're like they are more bulbous and raised off the skin. And then you have port wine stain, which is this where it just looks like you spilled a glass of wine. They can treat these with I think lasers. I think they can like blast the blood vessels and close them that way. But again, this is also just a cosmetic thing, not anything harmful. Usually people have these, like this would be like removed, you know, if they don't want that there. But these, I think they do laser to kind of like zap the vessels. I'm not really, because you obviously can't remove that. It's not raised, It's just flat. All right. Then we got nevi, I don't really know how you say that. These are just a fancy word for mole. Everyone knows what moles are. You probably have them. I've got one right here. I've had this since I was a child, my whole life. It's just a dark area of skin. You can be born with them, so it doesn't really have anything to do with sun exposure necessarily. Like I've had this my whole life. I mean, you can also develop moles later with sun exposure, but they're not necessarily. It's just an area of condensed melanocytes. You have just a bunch of melanin in one spot. That's all it is. All right, pityriasis. This is another fungal infection, and this tends to just cover the skin, like the trunk. It's just patches of flaky skin, either dark or light in comparison to whatever skin color you have. It can possibly leave a permanent color change if it's on there for too long. Really, you'll just use antifungal creams to deal with it.
This has that mother, right?
Huh?
This has that mother patch.
Oh, the Herald patch.
Yeah.
No, that one is oh, it doesn't matter. You don't need to know
I
it.
know, I was
Yeah.
just talking, but I thought that.
Yeah, I know what you're talking about. It's on the. I can't think right now. I'll look into that and answer you because now I'm curious. All right, then we have an abnormal suntan. So this is actually like your skin starts getting tan, and it has nothing to do with sun exposure. So it's not like you're laying out in the sun getting tan. You're just getting tan for other reasons. Some drugs can cause this. Like you take certain medications, it makes you start getting tan, and it's kind of weird. There's also some diseases, which we'll learn about when we get to the endocrine system, which is like the hormones and stuff. There's a disease called Addison's disease, which we haven't gotten to yet, but that can cause darkening and bronzing of the skin. But yeah, this is just, that's what that is. Alopecia, this is just balding, so loss of hair. It can be in patches like this man here, where it's just kind of like random clumps that are missing. That's called alopecia areata when it's the patchiness. Then there's what we call male pattern baldness, which is androgenic alopecia, which is the typical, like where you lose the hair on the top of the head and you just have the hair like down here by the ears, kind of like when you think of like a monk, like that's what it looks like. The monk hair is kind of what they call the alopecia, the male pattern baldness, which is a lack of, it has to do with their hormones being out of whack.
Yeah.
It can also just be from aging. It can be hereditary. There also can be some other illnesses that you can have that make your hair fall out. I don't know if any of you have ever had thyroid issues. Like when you have thyroid problems, your hair can fall out. Or postpartum hair loss. I had that real bad. Like postpartum, my hair was just coming out in clumps. I was like, oh God, I'm gonna be bald. Thankfully, it came back, but I was just like real worried for a second because the hormone drastic changes can cause the hair loss. The treatment for it usually is for the men with the alopecia, male pattern baldness, is the minoxidil. You've heard of Rogaine?
Yeah.
You've probably seen commercials and stuff for Rogaine. It's just a treatment to have your hair grow back, and it's one of those things you kind of have to take the rest of your life. Like it's not like you take it for a week and you're better. Like, because your hair is constantly needing help to grow. So like if you want your hair to grow, you have to keep taking it. Okay.
Oh, I need some of that.
You said you need some of that. All right, then we have warts. Anybody ever had a wart before? I've had when I was a kid, but I haven't had any since then. But they're actually caused by viruses. The same virus, it's the HPV virus, which you think of with like HPV with like STDs. But it's the same virus, but in a different location. So this is like on the skin rather than in the genital area. So warts are caused by viruses. They're very common on the hands and feet. They're spread by, close contacts. You're just like, very common in kids, again, because kids are nasty, right? They're touching everything, touching everyone. If you get the genital warts in the genital area, it's the same virus, but it's considered an STD, right? Because people shouldn't be touching down there, unless they're, engaged in sexual intercourse, right? So that's why it's a sexual transmitted disease. You can remove these with, they do freeze them off, so you can do cryosurgery. They do also have like topical, like creams and gels that like slowly like eat them away, and you kind of pull them off in layers. I thought that was fun when I was a kid. Like my mom would put the cream on my thumb because I had a wart there, and like in the morning I'd wake up and pull the layer off, and it would just slowly eat it down. It didn't hurt. It was just, I'm weird, I know. Yeah, so you can freeze them, burn them, medications. All right, folliculitis. This is pretty common. You may have heard of it. It's just basically, like when you shave, especially men, like on their beards, because their faces are sensitive, you can get like the inflammation of the hair follicles, So beards, anywhere, like using a razor can irritate it. So like people can get it like in their bikini line, shaving down there, you get like the bumps. That's the same kind of idea. Basically it's just bacteria are getting into those hair follicles, and they get in better like when you're using because it's just kind of making like microscopic little cuts in the skin. They are usually found on thighs, buttocks, or hair follicles. I've seen a lot of men get them on their neck, and they can get like a doctor's note. If their job requires them to shave, they get a doctor's note saying that they have folliculitis, and they can get away with having a beard type of thing. diagnosis, you just look at it, you just can tell. Treatment for this is going to be, you can either use topical antibiotics, but if it's really bad, you might need oral antibiotics to treat it, since it is from a bacteria. And then usually it's acute, if you treat it, but some people just have it chronically, especially if they, like anytime they use a razor and it keeps coming back. So it could be an acute situation or it could be chronic. And this is kind of, what that looks like, just the bumps on the hair follicle. All right, and this is actually our last one. So good. We got necrotizing fasciitis. This is very scary. It's like something out of a horror movie. It's a deadly flesh-eating bacteria. Yeah, I've never actually seen anyone with this, so that's great. But look at this prognosis. 1/3 of people who get this will die even with treatment.
Whoa.
Yeah, so that's real bad. Yeah. If you're squeamish, look away. I'm about to show you what it looks like. This is the flesh-eating bacteria on someone's arm.
Okay.
Yeah, so it's really bad.
Take my arm.
Huh?
You can take the arm.
You can take the arm.
Yeah, you can take the arm.
Yeah, it's awful.
Like this happened.
Yeah,
I just-
they
I
can't
don't want it
put
no more.
off.
I don't need it no more.
Oh goodness. Yeah. So very red, very swollen, severe pain, lots of blisters, ulcers, drainage. Bad fever.
Oh my gosh. How does that what's the cause?
It's just a real bad infection.
You know about
Damn.
you don't know how do they get it?
It's just it's getting into the skin some way. So you get it's a bacteria entering into the skin somehow. It's not super common. So I've literally never met anyone with this. Thankfully, we have we give them very aggressive IV antibiotics. Right, this isn't like, oh, we're gonna rub some Neosporin on it. No. You're getting IV antibiotics all day, right? Yeah, like vancomycin, because creams are like the weakest, right? You're putting something topical. Then oral is a little bit more intense, and IV drugs are the most aggressive because it goes straight into your bloodstream immediately, right? So if you have this, you're gonna be in the hospital getting IV antibiotics immediately, and that's that for the medication or for the diseases. We can briefly talk about these medications. A lot of these are, what's it called? Review from last week. So we've talked about steroids already, so I'll skip those. So we went over this. All of them end in zone or alone, right? And it just reduces inflammation, helps suppress the immune system. You can go back to the previous week and look at those. So here's some common antifungals. So they end in zole: fluconazole, clotrimazole, miconazole. These are often used for vaginal yeast infections. You can get them over the counter. You can use these for any of the taenias, right? The taenia capitis, the taenia corporis, the taenia pedis for the athlete's foot. There's ketoconazole, which is the dandruff shampoo, which is also fungal. This one is the only one that doesn't end in zole, but it's extremely common. Nystatin. Have you ever heard of nystatin? If you've worked in any kind of medical field, you've probably heard of nystatin. It's like a powder that you rub on people's skin folds, especially people that are a little bit overweight. They have skin folds and it gets really yeasty in there. And then terbinafine, I told you, was for the nails, right? Antihistamines, these are, I talk about Benadryl, right? They are for allergies, itching. A lot of people take these for pollen, right? You probably know all of these. Zyrtec, Allegra, Benadryl, Claritin. What do you notice about what they all end in? Ene, right? Cetirizine, diphenhydramine, yeah. So that that follows the pattern. We talked about antivirals already. They end in vir, makes it easy to remember. Only thing about them is that they think, oh, antivirals kill viruses. No, you can't kill a virus like you can kill a bacteria because they're not technically alive. We don't really understand viruses. They're the closest thing we can say is they're like robots because they're not living. They're not alive in the same way that we are alive, right? You can only keep them from replicating. So these drugs here, they just kind of prevent viruses from reproducing themselves, but you can't actually kill them. It's very weird. Okay, antibiotics. There are so many different antibiotics. I was not going to overwhelm you and make you memorize all of those. But what I will have you guys do is know these are the most common classes and what their endings are. So if you come across something that you've never seen before, then you can recognize it based on the ending. Okay, so penicillin, I'm sure you've all heard of penicillin, amoxicillin. It ends in cillin. Okay, so that's easy. Cephalosporins, they contain the word ceph in there, so like ceftriaxone or cephalexin. Okay, so I don't need you to memorize all these different antibiotics, but just be able to recognize based on the suffix or the prefix, okay? I don't need to read through all these. I think you guys can look at that on your own. I just want to explain a little bit because I don't want to run over on time here. Kind of a continuation of antibiotics. You know, minor cuts and scrapes, you put on a Band-Aid, you know, Neosporin, bacitracin. These are like things you get over the counter just for wound cleaning. That's pretty much it. There's not a ton. I think that's the last slide. Any questions about anything before you guys want to take your quiz? Open note, open book, open PowerPoint. If you're ready, I'm going to go ahead and open that up. There's a lot of integumentary, so I knew we would have a
Yes.
time to finish it. So I'm going to go ahead and stop this video too.